Hello students, so I guess I'm live. I'll be waiting for a couple of seconds for you to respond to me that I'm live, and then we will discuss the today's topics. Today's topics are focused on calculation. So we're getting back at mathematics. See, remember generally in a pool of 30 questions that you anticipate from medicine, often you might get roughly around 1 or 2 questions which are based on calculations. So in this module we will try to address some of the important ones. I'm not saying that I'm going to cover extensively all the formulas and calculations that come in medicine. We will stay focused. Okay, so first one, calculate the GFR for the patient with the following details. Patient name is Mr. Raman, his gender is male, he is 40-year-old and his weight is 60 kgs, serum creatinine is given and blood urea nitrogen is given. Now to calculate the GFR, right, what we call as estimated GFR, there are various formulas available. So you should know the names of the formulas. When in the exam they ask you question, mostly questions will be based on only one, that is Cockcroft-Gault formula. The other formulas are complex. They include sometimes logarithmic scale. So we don't employ them in examination. We can use a calculator and calculate in day-to-day practice, but not in the examination. So eGFR can be calculated with following equations. Okay. The one that is more consistently and commonly followed in real world practice, which requires a calculator, is your CKD EPI equation. CKD EPI equation. And the second one that is commonly asked in exam, that is Cockcroft-Gault equation or Cockcroft-Gault formula. Okay, so I'm going to give you this Cockcroft-Gault formula now, and then we will calculate the GFR for this patient. Now what are the information we need? According to this formula, we need the age of the individual, right? We need his body weight. Ideally speaking, the formula includes what is called as ideal body weight, but in this case we have put a correction factor. So as long as you know the weight of the patient, it's fine. So age of the patient, weight of the patient, serum creatinine of the patient, that's all we need, and gender obviously, because for males whatever result comes out of it is directly his GFR. For female we have to multiply it with 0.85. Clear? Okay, so now let us put that details in this question. So age of the individual here is Mr. Raman. He is male, he is 40-year-old, his weight is 60 kg, creatinine is 2, right? So let us employ that for this question. In this case, right, estimated GFR would be, according to Cockcroft-Gault formula, 140 minus age of the person is 40 years, right? 140 minus 40 into his body weight, which is 60 kgs, right? So into 60 kgs divided by serum creatinine into 72, right? So serum creatinine here is 2.0 or 2 milligrams. So let me keep it as 2 into 72. I would have multiplied it with 0.85 if it was female. Because this patient is male, I'm going to keep the formula as it is. So now if I apply that formula, what would be the GFR? 140 minus 40 would be 100 into 60 divided by 2 into 72 would be 144, right? 144. So once I employ this in a calculator, I will get the results, right? So let me calculate it with a calculator. In the examination, generally you will get simplistic numbers, not even complex number, which would require a calculator. Okay, so 100 into 60, that gives me 6000 divided by 144, that's equal to 41.6, right? 41.6. The normal estimated GFR would be greater than 90. So in that case, this patient's GFR is clearly decreased. So now what did we learn from this? There are 2 or 3 important MCQ points. Okay, the number one MCQ point is that what is the formula that can be used for calculation of the GFR? See, there are 2 things. One, actual GFR, which you estimate as a creatinine clearance with the help of inulin, not practically or routinely employed in clinical practice because it is a cumbersome process. So we use formulas, and among the formulas I wanted you to remember these two formulas. In the exam, if they ask you a question, mostly the question will be about the Cockcroft-Gault formula. In practice, 𝐒𝐂𝐈𝐴 equation is more commonly employed. Okay, next question. Analyze the following ABG report. pH of the person is 7.38, bicarb is 14 millimoles per liter, PaO2 is 80 millimeters of mercury, and partial pressure of carbon dioxide in his blood is 18 millimeters of mercury. So what do you think? This ABG, right? Options are right in front of you. Normal ABG, metabolic acidosis, respiratory alkalosis, respiratory acidosis. So what do you think? Do you think this is a normal ABG or not? If not, then what is it? So that brings one important question, right? What are the normal values of all these numbers, right? The normal pH is in the range of 7.35 to 7.45, right? Normal PaO2 is in the range of 80 to 100 millimeters of mercury. Rarely 100, 80 to 90 is the number that we should ideally remember. PaCO2, right? Partial pressure of carbon dioxide. That is also 35 to 45 millimeters of mercury. So here these two numbers are very prominent, like 35 to 45, that's your pH range. Same 35 to 45 that is your PaCO2 range. Now when I look at the ABG, it looks like okay, pH is normal, but when I look within the ABG, when I look into the bicarbonate, right, is bicarbonate, I forgot to mention you the bicarbonate values, right? HCO3 minus values, normal is in the range of 22 to 26 millimoles per liter. Millimoles per liter. Okay, now do you think this bicarbonate is normal? pH appears normal, right? Bicarbonate is low, PaCO2 appears normal, PaO2 appears normal, and PaCO2 it is decreased, right, less than 35. So can I call this as normal ABG? No, right? This is an abnormal ABG. So can I choose option A as answer? No, it is an abnormal ABG. I cannot rely on this, right? So I have to primarily focus on identifying an ABG abnormality despite having a normal pH. So I will call it as normal when all the components of the ABG, that is pH, bicarb and PaCO2, all these three are normal, then it is normal ABG. When I see that they are not normal, it is not normal ABG. Then what is it, right? So remember now, I will give you a quick approach to ABGs. I want you to remember that. Okay, so quick approach to ABGs. So whenever you see an ABG first, right, approach to ABGs. Okay, first, step number 1, look at pH. Okay, look at the pH. If pH is abnormal, if pH is abnormal, that means there is clearly a acid-base disorder present. Acid-base disorder is present. Okay, now if pH is in normal range, what is the normal range? 7.35 to 7.45. This need not mean that ABG is normal. There can be still an ABG abnormality, right? So in that case, if I encounter that pH is normal, then we should look at, right, PaCO2 and HCO3. Okay, if they are normal, that means there is no acid-base disorder. So pH normal, bicarb normal, PaCO2 normal, then there is no acid-base disorder. But if they are abnormal, any or both of these abnormal, that means there is a acid-base disorder present. Acid-base disorder present. A simple flowchart based approach, right? So first thing, look at the pH. If the pH is normal, it need not mean that it is a normal ABG. If pH is abnormal, clearly we know that there is an acid-base disorder, right? If pH is normal, we have to see the PaCO2 and bicarb. If they are also normal, then it is a normal acid-base, normal arterial blood gas analysis. But if any of one of them are abnormal, that means there is an acid base disorder. Okay, so now going back to the question that we had. In this question, pH is normal, right? But when pH is normal, we don't discard it as normal ABG. We have to look at the bicarb PaCO2, right? PaCO2. So I can clearly see that bicarb and PaCO2 are abnormal. That means there is an acid base disorder. So confidently I can rule out option A. This is not a normal ABG, right? Now then comes the question. What is it? Okay, ABG abnormality is there, but how would I decide whether it is acidosis or alkalosis when pH is within the normal range, right? Now I will tell you one important point. When you look at the ABG, right, when the pH is abnormal, it is very easy. All we need to do is, if the pH is less than 7.35, that means it is acidosis, and if the pH is more than 7.45, that means it is alkalosis, right? Now once we have decided that this is acidosis or alkalosis, how will we decide whether it is respiratory or metabolic? For that we have to remember one simple step here, right? To decide whether whatever abnormality that you have encountered, acidosis or alkalosis, whether it is respiratory or metabolic, to decide about respi versus metabolic, right? You have to remember, like, look at pH and PaCO2, right? Now if both follow same direction, then it is metabolic. I will explain what is it, right? Then it is metabolic. If they follow opposite direction, if both follow opposite direction, then the abnormality is respiratory, right? So it's a very simple way to remember it. There is a mnemonic for it called as ROME. Mnemonic is ROME. What is ROME? Respiratory, opposite, metabolic, equal, right? You can also remember with one more mnemonic, that is MS ortho. MS ortho stands for metabolic, same, right? Opposite, R here is respiratory, opposite, respiratory. Okay, so now when I say follow, what does that mean? For example, if the pH and PaCO2, right, both are in the same direction, like both are increased or both are decreased, they are in the same direction, right? That indicates that you have a metabolic abnormality. And the other thing, pH and PaCO2 may be in the opposite direction. That means pH is decreased, PaCO2 is increased, or pH is increased and PaCO2 is decreased. They are following the opposite direction. In such cases, it is a respiratory pathology. So let me give you an example here. Example, right? pH of the individual is 7.2, PaCO2 is, let me say, 25, okay, and bicarb of this person is 10. Okay, so now let me follow this approach, right? First thing, I have to look at the pH, whether pH is in normal range or outside the normal range. Here pH is clearly outside the normal range, so that means there is a acid base disorder present. When there is an acid base disorder present, now I have to decide acidosis or alkalosis. pH less than 7.35 is acidosis, more than 7.45 is alkalosis. So here it is less than 7.35. So that means whatever I am dealing here is a case of acidosis. Now I have to decide whether this is respiratory acidosis or metabolic acidosis. So for that I have to remember this ROME as the mnemonic. Respiratory, pH and PaCO2 will be following opposite direction, metabolic same direction. Okay, so now what is happening here? pH is decreased, PaCO2, normal PaCO2 is 35 to 45, it is 25, so it is also decreased. So both of them are in the same direction, right? If they are in the same direction, then it is metabolic. So looking at that, it becomes a typical case of metabolic acidosis. Clear? So this is how a simple ABG can be analyzed. Now the question is, what if the pH is normal? What do I do? If the pH is normal but still there is an acid base disorder, right? So in that case, right? To decide whether there is acidosis or alkalosis, to decide about acidosis or alkalosis, use 7.4 as cutoff, right? So normal range of pH is 7.35 to 7.45. In a case where acid base disorder is there and yet pH is normal, we will use 7.4 as the cutoff. Okay, so on this side of 7.4 is acidosis, on that side of 7.4 is alkalosis. Clear? Now I want you to remember also use what is the normal range of PaCO2, 35 to 45 millimeters of mercury. So we will use 40 millimeters of mercury as cutoff for PaCO2 to decide कि बाद में जाके हमको ये रोम अप्लाई करना है ना, to decide whether it is respiratory or metabolic, where we will use PaCO2 cutoff as 40. Less than 40 means PaCO2 will consider as decreased, more than 40 means we'll consider PaCO2 as increased. Clear? So now let us go back to this question and we'll try to approach this way. So we clearly know that this is not a normal acid base report because the bicarb is low and PaCO2 is low. Okay, now from the algorithm I have to apply the situation where the pH is normal, means pH is not in the outside the range, right? Now I have to decide acidosis or alkalosis. What is the cutoff that we are using? 7.4. Less than 7.4, in that case we will call it as acidosis. More than 7.4 we will call it as alkalosis. So here the pH is less than 7.4. So that becomes a clear-cut case of less than 7.4 with abnormal PaCO2 and HCO3. So in that case less than 7.4 becomes acidosis. If I had a pH of 7.38 and carbon dioxide were normal, then that would have been a normal ABG, right? So there is acidosis here. Now I have to decide respiratory or metabolic. For that PaCO2 is my bet. Now PaCO2 less than, if confusing, then we will use 40 as the cutoff. Here there is no concern at all because it is clearly decreased, lesser than 35. So PaCO2 is decreased, right? So now pH here will be technically considered as decreased because it is less than 7.4, and PaCO2 is also decreased in this case, right? So in that case what it becomes, both are in the same direction and pH is low, so it will become metabolic acidosis. So what should be the correct answer for this question? Option B, metabolic acidosis will be the right answer. Now sir, we have been studying that ABG means pH less than 7.35 is acidosis, more than 7.45 is alkalosis. But compensation नाम की भी कोई चीज होती है, right? If there is metabolic acidosis, that means kidneys are failing to clear the acid from your body, or your system is generating too much of the acids, then your respiratory system should try to compensate for that, right? How it will try to compensate for that? By eliminating carbon dioxide. By eliminating carbon dioxide. So the carbon dioxide is expected to decrease. So that is what we are seeing here. Carbon dioxide is decreased. Now if the carbon dioxide sufficiently decreases, the pH of the person will come back to normal. It will come back to normal. If it comes back to normal, like in this case, in that case we call it as a compensated metabolic acidosis. Means respiratory system is completely compensated. So we can also call it as fully compensated. So ideally speaking, this ABG is a fully compensated metabolic acidosis. Okay, on the other hand, let me say this patient's pH was 7.31, right? It is not back to normal range. है तो metabolic acidosis ही, क्योंकि pH decreased है, PaCO2 decrease है, दोनों same direction में है. So then it is metabolic acidosis. But whatever respiratory compensation is happening is unable to push the pH back to normal range. So in that case, I will call it as partially compensated metabolic acidosis, or it's definitely not fully compensated. You can either call it as uncompensated और partially compensated metabolic acidosis. जब भी pH normal के अंदर वापस आता है because of the compensation from the other system, then we will call it as compensated or fully compensated metabolic disorder, right? So this is a fully compensated metabolic acidosis. Okay, now the same ABG, analyze the following ABG report. I have given you an approach, you know it is the same number, so you know the answer already, right? This is certainly not a normal ABG because bicarb is low, PaCO2 is low, it's not normal. pH appears to be normal, but we remember that in the range of 7.3 to 7.45, whenever pH has come back to normal, we will use 7.4 as a cutoff to decide acidosis or alkalosis. Less than 7.4 is acidosis, more than 7.4 is alkalosis. So here it is less than 7.4, making it a case of acidosis. To decide between respiratory and metabolic, we will look at the direction of pH. pH is decreased, PaCO2 is also decreased, both are in the same direction, meaning Rome, correct, right? Rome means respiratory opposite, metabolic equal. So both are in the equal direction, making it a metabolic acidosis. And because pH is back to the normal range because of the effort of compensatory mechanism, we will call it as compensated metabolic acidosis. Even I can use the term fully compensated metabolic acidosis. Okay, next question, analyze the ABG. pH is 7.23, right? So pH is less than 7.35, making it a case of acidosis. Now, if it is a case of acidosis, I have to decide whether it is respiratory or metabolic. For that, I have to look at the PaCO2, right? PaCO2 here, normal PaCO2 is 7.3, normal PaCO2 is 35 to 45 millimeters of mercury. Here it is only 17. So that means it is decreased. pH less than 7.35, that means it is decreased. Both are in the same direction, right? Keeping this in mind, right? Remember the Rome, respiratory opposite, metabolic equal. So both are in the same direction. That means it is a case of metabolic. It's a case of metabolic acidosis. But in this question, when you look at the options, they're not talking about metabolic or respiratory. They're talking beyond that. What is that beyond? Okay, now we clearly know that this is metabolic acidosis. So certainly it's not respiratory acidosis or respiratory alkalosis. We have to choose option A or B. High anion gap metabolic acidosis versus normal anion gap metabolic acidosis. Okay, so for that, first we have to understand what is anion gap. Normally in human body, we have positive ions which are called as cations and we have negative ions which are called as anions. Body will have a perfect balance of the cations and anions. That is not like biology, that is physics and chemistry, right? If there is excess of one of the ions, right, basically it's an unstable chemical, right? And it can also lead to potential difference in the flow of electricity. So electrons will keep moving. So body will have equal number of cations and anions, but when we measure, right, we don't measure all the cations and all the anions. So there's a difference between the cations that we measure and anions that we measure. That gap is what we call as anion gap. Okay, so there's a formula for calculation of the anion gap. What is the formula? Okay, so let me give you the formula for calculation of the anion gap. The formula for calculation of anion gap is anion gap equal to sodium. Sodium is the most important cation in human body. Apart from that, yes, there is potassium, there is calcium also, but for the simplicity, we only account for sodium. Sodium is the most important cation, and among the anions, the larger anions are primarily bicarbonate and chloride. So we employ this formula for calculation of the anion gap. Okay, so just give me a second, guys. Okay, so now if anion gap is defined that way, then let us calculate the anion gap. Anion gap equal to sodium minus bicarb plus chloride, right? So the normal anion gap is in the range of around 12, right? When it is less than 8, we call it as low, and when it is more than 12, you will call it as high. I want you to remember 12 as the number. More than 12, we call it as high anion gap metabolic acidosis. So normal anion gap is approximately around 12. So when you have a metabolic acidosis with anion gap less than 8, we call it as low anion gap metabolic acidosis or 𝐼𝐴. And when anion gap is more than 12, we call it as high anion gap metabolic acidosis or 𝐼𝐴, right? So let us calculate in this case. In this case, we have the information of sodium. Sodium is 123, bicarb is 7, chloride is 97. Okay, so sodium is 123. 123 minus bicarb is 7, chloride is 97, right? So that becomes 123 minus 7 plus 97 is around 104. Correct me if I am wrong, right? So that makes the anion gap as 123 minus 104. Please excuse my poor mathematics. I wouldn't have landed up in medical education if my maths was good. Certainly I would have chosen an IIT. So 13 minus 4 is 9, 2 minus 1 is 1. Okay, so the anion gap here is 19, right? 19. So what is the normal anion gap? 12. Anything more than 12 means we have a case of high anion gap metabolic acidosis. So what should be the answer for this question? Answer would be option A. We have a high anion gap metabolic acidosis. Now, why is it important for us to understand the anion gap? Because if I encounter an ABG, I recognize that there is metabolic acidosis. The anion gap will help me to shortlist the differential diagnosis. What could be the cause for metabolic acidosis? So in the exam, mostly they will ask you the causes for high anion gap metabolic acidosis, and there is a simple mnemonic available in Wikipedia that can help you to remember the causes for high anion gap metabolic acidosis. High anion gap metabolic acidosis, or HAGMA. What is the mnemonic? CAT mud piles, right? CAT mud piles. So in the CAT, C stands for carbon monoxide, cyanide, congenital heart failure. A stands for aminoglycosides. T stands for theophylline and toluene, right? What is toluene? The glue that many rag pickers sniff and sometimes they get intoxicated and come to hospital, right? Mud piles ka M stands for methanol. Mud piles ka U stands for uremia. So that's why CKD is a, remember now this is again an important MCQ point, right? Remember CKD is a cause for high anion gap metabolic acidosis. High anion gap metabolic acidosis. Okay. CAT mud piles ka D stands for diabetic ketoacidosis, right? Alcoholic ketosis, starvation ketosis. So all ketotic conditions cause high anion gap metabolic acidosis. So again, DKA is another example for high anion gap metabolic acidosis. Okay. Then mud piles ka P stands for paracetamol poisoning. Again a repeatedly asked question. Paracetamol leads to metabolic acidosis. Which type? High anion gap metabolic acidosis, right? I stands for iron, isoniazid and inborn errors of metabolism. L stands for lactic acidosis. So in various conditions lactic acidosis can happen. Typically in medicine we encounter that with sepsis. Okay. Then E stands for ethanol. Ethanol also again leads to lactic acidosis, and S stands for salicylates, including aspirin, right? At least the ones that I have highlighted are something that are important for you to remember as the causes for high anion gap metabolic acidosis. One more important MCQ. Okay, now let us move to the next formula based question. So here we have to calculate the serum osmolality. Parth Prajapati, absolutely right. Yeah. So we have to calculate the serum osmolality. Now what is osmolality? It is basically representing the relative concentration of solutes in a fluid. Okay. And in human beings, the serum osmolality primarily depends on three important osmotically active substances. What are those? Sodium, glucose and urea. These are most important osmotically active substances in human blood. Okay. And among them, the single most important factor that is responsible for serum osmolality is sodium. Okay. So if higher the sodium, you expect the osmolality to be higher, and when hyponatremia happens, if there is a true hyponatremia, the sodium will be low and the serum osmolality will also be low, right? If you have a low sodium but serum osmolality is normal, that is a case of pseudo hyponatremia. Okay, so now let us calculate the serum osmolality. Okay, so there is a simple formula for serum osmolality. There are three components. What is that? Sodium, blood urea nitrogen and glucose. Okay, so for calculation I need sodium, blood urea nitrogen and glucose. So let us interpret that data. So in this case, the formula says sodium should be multiplied with 2, right? So 2 into sodium is 120 plus blood urea nitrogen is 14. It should be divided by 2.8 plus glucose. The serum glucose here is 180. It should be divided by 18. So in that case, 2 into 120 will be 240 plus, can anybody tell me what is 14 divided by 2.8 with the calculator? 180 divided by 18 would be 10, right? So 14 divided by 2.8, let me also use the calculator. 14 divided by 2.8, that comes out to be 5. Okay, so here the serum osmolality is 255. Okay, so now let me tell you what is normal serum osmolality. Normal serum osmolality. Normal serum osmolality is 280 to 290 milliosmoles per liter, right? That's the normal serum osmolality. Okay, now in what conditions serum osmolality can be increased? When you have hyperglycemia, like in diabetics, right, especially diabetic ketoacidosis, when there is sugar level very high, or in CKD patients where the urea level is very high, right, and in severe hypernatremia where sodium level is very high. In what conditions there can be decrease in the serum osmolality? The decrease in urea or glucose may not affect the osmolality much, but a decrease in sodium should, right? Because that is the single most important contributor. Out of 255 in this case, 240 is coming from sodium itself. See, for urea we are dividing it with a factor, for glucose we are dividing it with a factor, but sodium we are multiplying. So sodium is the most important contributor to the serum osmolality, right? So if you have a case of hyponatremia, right, in a case of hyponatremia, if serum osmolality is less than 280, right, that means it is a case of true hyponatremia. It's a case of true hyponatremia. And if serum osmolality is more than 280 milliosmoles per liter, that means it's a case of pseudo hyponatremia. They do ask you the examples for pseudo hyponatremia, right? What are the examples? I'll give you a few examples. Okay, first one, hyperglycemia. So whenever blood glucose level is high, see, body will try to maintain the serum osmolality. So if I increase the glucose, what will happen to sodium? To keep the serum osmolality constant, body has to decrease the sodium. Body shifts the sodium from the extracellular compartment to intracellular compartment so that the serum osmolality remains constant. So obviously sodium in the blood will be low in that case when the glucose is high. So that is one reason for pseudo hyponatremia. Okay. Second, hypertriglyceridemia. If the triglyceride levels are high, they will trick the machine used for calculation of the sodium. Okay. Third, paraproteinemias, like your multiple myeloma, paraproteinemias. In these three conditions, you can have pseudo hyponatremia. Okay. Now let us move to a next question based on calculations. So in this question, primarily we have to assess the risk of a stroke in a patient. Parth Prajapati, yes. So the SIDH is a case of true hyponatremia. So you will have a serum osmolality low. That's why if you go back to SIDH, there is a diagnostic criteria called as Barter and Short's criteria, which says that first step to diagnose SIDH is that there should be hyponatremia. Sodium should be less than 135. The second step is that with hyponatremia, there should be hypoosmolality of the plasma. The plasma osmolality should be less than 280. If it is more than 280, it is pseudo hyponatremia. It's not a case of SIDH. Okay, sometimes that appears in MCQ also. Which of the following is false about SIDH? And they will mention serum osmolality more than 280. That's a false statement. Okay. Now, in this question, we have a 50-year-old male who presented with slurring of speech and right-sided weakness, which lasted for 2 hours and resolved, right? Now, can I call this as a case of stroke? A patient with right-sided weakness means unilateral weakness, which lasted for 2 hours and resolved. Can I call it as a case of stroke? No, right? Then what should I call it as? If the focal neurological deficits improve within 24 hours, we call it as TIA, right? So because here the improvement has happened within 2 hours, it is a case of TIA, transient ischemic attack. Now, if the patient has transient ischemic attack, most probably what has happened, there was a transient block in one of the blood vessels, either carotid or its branches like middle cerebral artery or anterior cerebral artery, and because of that, the area that did not receive the blood, the area that was subjected to ischemia, lost its functions momentarily. But after that, the block got cleared by physiological processes and the blood flow was re-established, and once the brain started getting the blood flow, it regained its function. But if it has happened once, that means that there is a risk of stroke, because the block got cleared now. It need not always get cleared. The next block may not get cleared and it might lead to stroke, right? So now I have to assess the risk of stroke in a patient who had a TIA. Now how do we assess the risk of stroke in a patient with TIA? The risk of stroke in patient with TIA is assessed by risk of stroke in patients with TIA is assessed by a scoring system called as ABCD2 score. ABCD2 score. Okay, this score is pretty easy to remember and a multiple time asked topic. In fact, this is a PYT, previous year topic. Repeated questions have appeared. So most of the questions that have appeared so far in the FMGE are like, which of the following is not a component of ABCD2 score. Okay, but now onwards we can also expect them to ask us to calculate the ABCD2 score and decide what is the risk of stroke. Okay, so what are the components? ABCD2 itself is a mnemonic, so that is pretty damn easy to remember. So A here stands for age more than 60 years. B here stands for blood pressure more than 140/90, any one of them, either systolic more than 140 or diastolic more than 90. Then C here stands for the clinical features, right? What are the clinical features? Whether patient had a unilateral weakness or patient had speech disturbance without weakness. Okay. Then D here in the ABCD2, the D stands for duration of symptoms, how long the focal neurological deficits lasted, whether they lasted for more than 60 minutes or whether they lasted for less than 60 minutes, and if they lasted for less than 60 minutes, whether they lasted for 10 to 59 minutes, and whether patient has got diabetes. So that's whether D2, right? ABCD2. Now let us look at the question and assign the ABCD2 score for this patient. Okay, now this patient is a 50-year-old male. Gender wise, he is male. He has unilateral weakness along with speech disturbance. Symptoms lasted for 2 hours and resolved. He is a known case of hypertension, that means his BP is on the higher side, and he is also a known case of diabetes. Clear? Okay, so now age of the person is, remember, it is 50 years. So how much score I should give for the age? I will give 0 points because age is not more than 60 years. Blood pressure 150/90 and he is a known hypertensive, so BP is on the higher side. I will give 1 score for this patient, right? Clinical features wise, he has unilateral weakness, he has speech disturbance. So whichever gets the highest score, we should assign that. So unilateral weakness gets 2 points. He had right-sided weakness, so I will give him 2 points. Okay. In terms of duration of symptoms, his symptoms lasted for 2 hours. Anything more than 60 minutes, I should give him 2 points. Okay. And he is a known case of diabetic, so I will give 1 point. So what is the total score of this individual? 1 plus 2, 3, 5, 6, right? So in this case, the score ABCD2 score is 6. In this case, the ABCD2 total score is 6. Okay. Now simple thing you need to remember is the score 0 to 3 is considered as low. That carries low risk of stroke happening, right? Around 1% risk of stroke happening in next 2 days, 1.2% in this 1 week, and 3% in next 3 months time. If the score is 4 to 5, there is a moderate risk of stroke, relatively higher risk of stroke happening in next 2 days, 1 week, as well as 90 days. And if the score is more than or equal to 6, right, 6 to 7, then the stroke risk is high. Almost like close to 20% of these patients will suffer from a full-fledged stroke in next 3 months, right? So in this case, the score is 6. So that means it is a case of high risk stroke, right? High risk of stroke happening in the next 2 days, 7 days and 90 days. So the question wise they're asking you, his risk of developing a full-fledged stroke in next 2 days is obviously high, right? It is not low. Low is when the score is 0 to 3, right? And high is when it is 6 to 7. Anything in between will be considered as moderate. So I want you to remember ABCD to score and its components for this upcoming examination. Now the last question for the today's session. Again, there is one more scoring system which has been repeatedly asked in the questions, exams. So we will spend some time on this. We have a 30-year-old female who was diagnosed with chronic atrial fibrillation. Now this atrial fibrillation is slightly different from the atrial fibrillation that have generally dealt in the cardiology class. So in the cardiology class, our focus was on acute cases of atrial fibrillation, right? Chronic means which is running for several long period of time. In such cases, the chances of converting that to sinus is as such less. Okay. So now if you have a chronic atrial fibrillation, we have to probably think about anticoagulation for sure. In case of the acute atrial fibrillation, if the duration is less than 48 hours, there is unlikely that a clot would have formed. We don't need to think of anticoagulation. We have to rather think of converting the rhythm to sinus. If it is acute but more than 48 hours in duration, there is a chance that there may be a clot formed. So we have to do an echo to see if there is a clot in the left atrium, preferably a transthoracic echo. If there is a clot, anticoagulate and then convert the rhythm to sinus. If there is no clot, directly convert the rhythm to sinus. How to decide that in those cases, in acute cases, whether the sinus conversion should be done with the shock or pharmacotherapy? Simple rule: BP less than 90/60 shock, right? BP more than 90/60 drugs. Simple. Okay. But if it is chronic, the chances of converting it into sinus is low. To prevent the risk of patient developing a clot in the left atrium and then getting it embolized and developing a stroke, we have to think about anticoagulation, right? But in all circumstances, we have to balance the risks and benefits. If the risk of patient developing stroke is low and if I give anticoagulants, I might end up creating a hemorrhagic stroke. On the other hand, if risk is high and I don't anticoagulate, I might get an ischemic stroke. So I have to balance it. For that balancing, we have a scoring system called as CHAD-VASC score. To be more precise, it is called a CHA2-DS2 VASC score, which helps us to decide whether we should give the full-fledged anticoagulation to a patient with chronic atrial fibrillation or just give aspirin. Okay, so now let us go through the question and understand how to apply that. What are important things in this case? The age will be an important factor. Okay, then whether patient has got any structural heart disease will be an important factor, because if there is a structural heart disease like rheumatic heart disease, mitral stenosis and all, we have to give anticoagulation. There is no need for the CHA2-DS2 VASC score in case of a valvular heart disease, right? We have to remember that. So I will give you a list where we don't need to look for the CHA2-DS2 VASC score. That is also an important MCQ. Okay. Then gender. This is not a known case of, right? History of diabetes, hypertension and heart failure is important. Previous history of stroke or TIA is also important. Okay. Now with all of that, let us look at the CHA2-DS2 VASC score, right? We call this as CHA2-DS2 VASC score. So what are the components of this score? C here stands for the congestive heart failure, in simple words, heart failure, right? H here stands for hypertension. Okay. A here stands for age, and we are using the term 2 here because if age is more than 75, we are giving 2 points, right? 2 points. That's why it is like CHA2. Then D stands for diabetes. S stands for previous stroke or TIA, right? We have to remember here that not only stroke but even TIA or TIA. Okay. And S also we are addressing it as 2. CHA2-DS2 because if there is stroke, we are giving 2 points. And then V stands for vascular disease. If patient had a peripheral vascular disease, thromboangiitis obliterans or a carotid stenosis, 1 point. And if the age of the individual is not more than 75 but still on the higher side, like geriatric population 65 to 75, 1. So this A stands for age 65 to 75. Last one is sex category, right? If it is female, we give 1 point. So let us assign the score for this patient. Age of this patient is 30 years, right? So on age criteria, patient will get 0 points, neither 2 nor 1, 0 points, right? Patient does not have heart failure. She is not a known case of diabetes, hypertension, heart failure, no history of TIA or stroke, right? So for congestive heart failure, 0 points, right? For stroke, 0 points, hypertension, 0 point, diabetes mellitus, 0 point. They have not mentioned anything specific about the vascular disease in the question. If it is not mentioned, it means it is not there, 0 point. So patient will get only 1 point for being female, right? So what is this total score here? So in this case, the total score is 1 point. Total score is 1. Okay. Now what are the recommendations? There are two conflicting recommendations. Ignore the Chest Society recommendation. We follow American Heart Association, American College of Cardiology recommendations, which recommends that for a male, if the score is more than or equal to 2, we have to go for anticoagulation, right? For a male, if the score is more than or equal to 2, anticoagulate. And for a female, if the score is more than or equal to 3, anticoagulate. So in this case, obviously the score is not more than or equal to 3. She is a female. The score is only 1. So what should we do? If the score is less than this number, right, we have to just give them aspirin. If it is more than this number, along with aspirin, we also give anticoagulation, right? So I will give you the interpretation of CHA2 DS2 VAS score. CHA2 DS2 VASC. For male, for female. Okay, for male and for female. So for male, if it is more than or equal to 2 and less than 2, less than 2 means 0 to 1, right? More than or equal to 2, anticoagulation along with aspirin. Aspirin is like the basic treatment. If it is less than 2, aspirin alone. No need for anticoagulation, only antiplatelets, no anticoagulation. For a female, if the score is more than or equal to 3, anticoagulation plus aspirin. And if the score is less than 3, that means 0 to 2, in such cases, aspirin alone, no anticoagulation. So because this case fits into the score of less than 3 for a female, there is no need for anticoagulation. Aspirin alone will be there. Now one last point we need to remember is that if we are giving anticoagulation, what should we choose? Warfarin, or there are something called as direct acting oral anticoagulants or DOACs. So all the guidelines recommend that we should prefer using direct acting oral anticoagulants like apixaban. Like examples I'll give you if you're not familiar. Like apixaban, right? Dabigatran. I'm just giving you a few examples. Okay, so these are preferred, but for a case of rheumatic valvular heart disease or those with prosthetic valves, we prefer vitamin K antagonists. So one last note here, anticoagulant of choice, which one we should use? Because sometimes question need not just say that, okay, we will anticoagulate. They will ask you precisely what will we use, right? If rheumatic heart disease, right, or metallic prosthetic valves, in both these cases, it has to be only vitamin K antagonist like warfarin. On the other hand, if non-valvular cause for atrial fibrillation, right, or patient with bioprosthetic valve, not metallic, bioprosthetic valves, where the valves are made from sheep tissue or goat tissue and all, in those cases direct acting oral anticoagulants preferred. Clear? Okay, now last one point, right? Conditions where anticoagulation initiated regardless of CHA2 DS2 VAS score, regardless of CHA2 DS2 VAS score. This is again a potentially important MCQ point for this year. Number one, the patients who have RHD, right? If there is a rheumatic heart disease, you don't need to look at the CHA2 DS2 VAS score. Start anticoagulant. Even if the CHA2 DS2 VAS score is 0, start anticoagulation. And what should be your anticoagulant of choice? Obviously for rheumatic heart disease, it has to be warfarin, right? And for all patients who have hypertrophic obstructive cardiomyopathy, right? And then patients with previous history of stroke or TIA. In those cases, you don't need to really think too much. Directly start the patient on the anticoagulant, right? Okay, clear? Now coming back to the question, what should be our answer here? The answer should be aspirin alone, because the score here is only 1, right? Score here is 1, less than 3 for a female, we will be giving aspirin alone. Okay. So if I change that, like let me mention that patient is diabetic, okay, and there is a previous history of stroke, then I have to go for anticoagulation, right? So in this case, if I mention that there is diabetes and previous history of stroke, what will become the score? Score will become 4. Diabetes के लिए 1 and then stroke के लिए 2, right? DS2, CHA2, age more than 75 and stroke, that get 2 points, everything else get 1 points. So 2 point here, 1 point here, and 1 point for gender, it becomes 4. It is more than 3. I have to start the patient in addition to aspirin, anticoagulation. Now which anticoagulant I should prefer? For all general cases, I should prefer a direct acting oral anticoagulant. But if there is a rheumatic heart disease or a patient has got a prosthetic, that to metallic prosthetic valve, then I have to go for warfarin. In this case, there is no structural heart disease that has been mentioned. So in that case, if I make the score 4, I should choose aspirin plus dabigatran, right? That is how we interpret the CHA2 DS2 VAS score. So that's it from me, guys, for today. So we have covered some 5 or 6 important scores in the run up to the examination. These should be enough. I know there are plenty of other formulas and equations, but at least ABG, ABCD2 and CHA2 DS2 VAS, I want you to remember completely. I am anticipating 1 question between these 3. Hopefully whatever time you have spent last 40 minutes with me should help you to get 1 marks. If there are doubts or if you encounter questions where you're not able to solve the ABG or the CHA2 DS2 VAS score is conflicting or ABCD2 score you're not able to interpret, you can DM me on the Telegram. I will respond to that. Right? Thank you all, guys. Thank you. Now I will be wishing you all the best for the upcoming examination. Stay focused and remember 1 point, right? Consistency for next remaining 25 days will beat last 3 months of hard work. There may be someone who has worked hard for last 3 months, but now he becomes lazy for next 25 days. And take examples of yourself. You being consistently preparing well for next 25 days, you will outclass the person who was working hard for last 3 months but now becoming lazy. So don't become lazy. Stay focused, right? And please don't have the fear that I have not completed the syllabus, right? Truth is that even after 13 years of completing my MD medicine, I have not completed the entire medicine. There are still areas that I don't know. There are still areas which I consider not important, so I have not spent time with. So you will never, no one will ever go into the examination hall feeling that, okay, I have completed all the syllabus. That's impossible. All your colleagues who are entering into the examination hall, before entering the examination hall, look at their faces. Their faces will tell the story that, okay, मेरी जिंदगी भी झंड है, आपकी भी झंड है. So सब एक ही बोट पे है, सबका गोल एक ही है, to get that 150. So you will be able to reach that 150 when you stay focused and you are confident, right? So with this, I am signing off, guys. From tomorrow, probably PW would start with the other subjects. My suggestion is that attend only the topics or systems where you find value or where you need to spend time on those topics, right? Because there is very short span of time before the examination. Rather, I would suggest that revise the important topics which you have already done. That will give you a better yield. But yes, there are some high yield topics, like for example ABG or this scores that we discussed. If there are other similar topics from the other subjects, please attend these sessions and learn from them. With this, I'm signing off, guys. All the best and have a good night.